My name is Dr. Ashok Seth from New Delhi, India. I guess you all know me, one of the past presidents of the Cardiological Society of India. And with me is one of the international authorities in interventional cardiology, a friend for a long period of time. We have here Professor Antonio Columbo from Milano in Italy. Antonio, welcome to India and welcome to Lucknow.
Thank you. Very impressive conference, lot of attendance, general cardiology and interventional cardiology. We discussed several topics. Maybe we can start with some of them. What do you?
Yeah, Antonio, your talk on drug-coated balloons today was great. And firstly, how you seem to be taking new frontiers with drug-coated balloons. You've always had very, how should we say, dramatic thought processes, radical in some ways. Tell us more about the drug-coated balloons and its use in our lives.
Should not be seen like an alternative to stents. But I believe in the last 3 or 4 years we have been using drug-coated balloon as a complement in order to avoid very long stents. Initially I promoted long stents, but I think the arteries loses physiology when you implant too much metal. So if you can limit the metal to the area where there is real recoil, where there is a bad dissection, please remember bad dissection, not dissection, then you may limit the foreign body and using the drug-coated balloon be able to deliver the antiproliferative medication in the vessel wall and obtain long-term patency. This hypothesis is to be tested because we do not have a lot of data, but preliminary data are in favor of that.
Antonio, I think the thought processes obviously come from the fact that we want a metal-free artery. We sort of collaborated a lot during the bioresorbable scaffold days when we put our data together with the Milano data for that publication, which had some real complex lesion subsets. But we together demonstrated that if you did it right, you did have good long-term outcomes, even with bioresorbable scaffolds. You think, and I miss them, I must tell you that. I miss bioresorbable scaffolds. Again, concept of metal-free artery.
I totally agree. Our primitive bioresorbable scaffold demanded a lot of attention to lesion preparation, IVUS after absorb implantation, etc. But our result, contrary to the randomized study, were very good. And I'm convinced that with the new generation bioresorbable scaffold, everything will be easier. Will still be more demanding than metal stent, but will be easier. But if we could complement bioresorbable scaffold, and again, stents are absolutely necessary. Don't believe that you can do PCI without stents, but bioresorbable scaffolds and DCB will be a real turn of the chapter 360 degrees. And I look forward because nowadays we have good bioresorbable scaffold, at least 2 or 3 in my mind.
Yeah, and we in India worked out into the thinner strut bioresorbable scaffold, the 100 micron scaffold. And I guess that we've seen some tremendous results from, especially because we had the learnings of the thick strut BRS earlier, which is absorbed. And so I think we're now ready for randomized trials on our thin strut 100 micron BRS as well. I was just thinking about the data which we put together on BRS at that time, which got published in, I think it was the International Journal of Interventional Cardiology, a Journal of Interventional Cardiology. I still recall, Antonio, that our implantation, our post-dilatation pressures were mean of 21. Our bed preparation was fantastic. Our imaging was as high as 80%. And I do recall that our mean scaffold length in the data which we put together, which was a 3-year follow-up, if you recall, scaffold length was 38 millimeters with 80% type B2C lesions. And we, at the end of 3 years, our scaffold thrombosis rates were 0.6%. So
yeah, was
so we
less
did,
than 1%.
Yes.
Less. I remember individually the 2 patients who had thrombosis in our series, over 300 patients. So one topic that I would like not to leave not discussed is the imaging.
yeah.
Imaging is important, but we have to be realistic and practically. We cannot pretend 100% imaging, and we cannot pretend OCT all the time. So let me ask you, when in your laboratory you perform imaging in real life,
Yeah.
and when you do imaging, when you do IBUS and when you do OCT?
That's a great question, and I think, to be fair, and we work under all sorts of constraints, not necessarily of the device itself, but all sorts of reimbursement and financial constraints. Very clear that imaging occurs in around 25 to 30% of our patients realistically. And one very clear around is that complex lesions, which means long lesions, heavily calcified vessels, left main bifurcation has to be 100%, I would say. And of course, instant restenosis, again, to me is 100%. Once we come to those, then of course that leaves behind the remaining 70%, which are usually the much more, should we say, A, B1, B2 type lesions. OCT and IVUS, imaging we should consider together, but what is clear is left mains, I'm 100% IVUS. Those MSAs which correlate with outcomes for me were IVUS derived and therefore matter to me in accuracy, in terms of providing best outcomes. I think where I love OCT is calcium, perhaps. The ability to see the depth of calcium, the ability to analyze calcium more and therefore act on it according to the devices we have. I'm more comfortable with OCT. So I have a clear differentiator there. Obviously, we have other contraindications to OCT, but I'm not going into that. I'm just going into the lesion subsets of OCT versus IVUS. So I'm definitely more in favor of IVUS, and all the measurements which correlate with outcomes are actually IVUS derived. In fact, I go back to saying that, Antonio, when stent came out, the only reason the whole world took on stents was because you, along with Jonathan Tobis at that time, actually gave us IVUS-derived implantation of stents. And you said bigger is better. And at that stage is when IVUS transformed. It was IVUS which transformed from balloon angioplasty to stents without having stent thrombosis.
Many years. I totally agree with what you said, and in the interest of time, I don't want to repeat. I totally agree. Final point regarding calcium. I personally like lithotripsy. It's expensive, that's the drawback, but if you in your cath lab have a hot ablation and lithotripsy and a good high pressure balloon, to me the calcium story is finished. The hot ablator to get the device there, high pressure balloon to facilitate lithotripsy. After lithotripsy, again some high pressure balloon, IVUS to check, lecture finished.
That's great, Antonio. Your messaging has always been very practical. It got the world to where it is in interventional cardiology.
Thank you.
Having lived in the same time frame as you and having been a friend of yours for such a long period of time has been indeed a pleasure and a privilege.
Okay.
Thank you, Antonio, to be here in India.
We met by chance today. So it was a real unique time to get together after many years.
Thank you.
Thank you.